We present the technique of arthroscopic ultrasound-guided needling for rotator cuff calcifying removal. The first step is preoperative ultrasound performed during the final consultation. We record the size of each calcification for each tendon on the longitudinal and transverse planes, as well as its depth, and the distance between the long head of the biceps and the calcification. We perform the same sequence just before surgery under general anesthesia and interscalenic block. Sometimes calcification is not visible, especially in patients with a high critical shoulder angle, because the acromion is generating an acoustic shadow cone that masks the deposits. Preoperative ultrasound data is therefore helpful to identify the specific area by a traditional needling technique. But if calcification is well visible, we perform an ultrasound skin marking. The acromion relief is drawn. We begin to find the calcification in a longitudinal plane. Then we mark the skin in the middle of the edges of the probe. The same sequence is improved in a transversal plane. The intersection of those 4 points correspond to the orthogonal projection of the calcification on the cutaneous plane. After the surgical drapes have been placed, the ultrasound probe and gel are covered in a sterile sleeve to be used during the procedure. Rigorous positioning of elastic is important. A technical fault may cause an alteration of visibility. We first present the longitudinal technique, the needle being positioned parallel to the major axis of the probe. It's the easiest one, but increases the distance between the point of penetration of the needle and the topography of deposits. The subacromial space is first explored and a progressive bursectomy is performed to visualize the superficial surface of the tendon. Irrigation is reduced. Probe is put at the ultrasound skin marking point to identify the calcification, and the 24-gauge hyperechogenic needle is positioned in the center of the calcium deposit under ultrasound guidance. Once the ultrasound step is finalized, the surgical assistant is asked to maintain the needle immobilized in the correct position during the arthroscopic phase. After washing and complementary debridement, the transfixing needle is visualized in the superficial surface of the tendon. In case of doubt, a second needle can be inserted to explore around the hyperechogenic needle and confirm the topography. Finally, the superficial surface of the tendon is opened with a cold scalpel and an electrocoagulation probe, and the contents are removed with a hook and a mechanical resector. The second method is the transversal one. We recommend it for calcification of the subscapularis tendon. It's technically more difficult, but reduces the distance between the point of penetration of the needle and the topography of the deposits. We only visualize the tip and not the entire needle. At the end of the procedure, remaining calcium residue is searched for by ultrasound and resected if necessary. This non-irradiating technique overcomes the disadvantage of fluoroscopy due to the compact size of the device and more precise three-dimensional images.